All right. So I'm Hawk Yoon. I'm an associate professor of ophthalmology here in Chicago at Lurie Children's Hospital. Um, we have a wonderful set of panelists today, and they run the gamut from academic to private practice. And you'll be hearing from them in a little bit. And they will give you the width and breadth of how awesome we are. Pediatric ophthalmology, this is the reason you go into to be a doctor. Pediatric ophthalmology really, I believe, reaffirms every day why we went into medicine. We love what we do. It's fantastic. It's fun. Um, it's heartwarming. It could be heartbreaking. You cry sometimes, but you laugh a lot. Okay. Um, Pediatric ophthalmology is the few, the proud, and the mighty. One of the best things about pediatric ophthalmology is you are the primary care giver for these kids, and the subspecialist and the surgeon. Okay, so you don't you this the variety of stuff you're going to deal with is amazing. There's never a dull moment because you do primary care and are the specialist, and then you get to work with your hands to do surgery. That also means you get to collaborate with tons of other people, tons of other pediatric specialists, be it neurosurgeons, primary care physicians, infectious disease, rheumatology. It really lends itself to a lot of collaboration. I'm going to dare say, in comparison to some of the other ophthalmology specialties, there's a lot more collaboration in peds than the other specialties. As we talked about, you are the subspecialist. You are the expert in so many things that are just, pediatric concentrated. And that leads to things being super interesting. But because, again, you are the primary care person, the subspecialist, and the surgeon, that leads to a lot of practice flexibility. You can be a little bit more of a subspecialist, a little bit more of the primary care person, a little bit more of the surgeon, depending on what you want in your work-life balance. And that finally means that there's a lot of need and opportunity. We are a small subspecialty. We want you to know about us and be interested in us because we need more people to go into it. So on any given day, we're dealing with googly eyes, eye tumors, cataracts, brain tumors, amblyopia, syndromes, retinopathy prematurity. Something that I've gotten into relatively recently is fetal medicine. In some strange way, the fetal medicine department here at Lurie is calling me for these consults. So again, if you look at the breadth of what we do, because we're the primary care people for kids' eyes, we do everything. We don't just do glaucoma. We don't just do cataracts. We do the breadth of it, which is pretty fun. The pathway is that you have to get into ophthalmology residency first. So that is the big elephant in the room. It's competitive. It is competitive, but not to sound silly, but if I can do it, anybody could do it. You work hard, and we all continue to work hard, but you do an ophthalmology residency, and then you do a one-year fellowship in pediatric ophthalmology and strabismus. And as all of the panelists know, there are more of us retiring than we are training, which is why we're here, frankly, to try and recruit people to get interested in pediatric ophthalmology. Okay. Again, one of the goals of tonight is to connect a lot of people to us, the panelists, and other pediatric ophthalmologists to help you if you want to be serious about this, not only get into pediatric ophthalmology, but of course get into ophthalmology to start with. And we'll talk a little bit about that later. My particular path, again, everybody of the panelists is going to give their particular story. Again, not because my story is special, but we want to make these connections. I grew up in Idaho. I went to University of Chicago as an undergrad. Classic country mouse. Went to the big city. Got mugged my first summer there. I spent 2 years in the Peace Corps. I went to medical school at Utah. residency at the Medical University of South Carolina Storm Eye Institute, and then Kellogg Eye Center for my fellowship, and then to my first real job ever here at Lurie Children's in Chicago. A couple of things, just to be very frank and blunt with you guys. There are some myths about pediatric ophthalmology that I want to address right off the bat. If you talk to some people, they may say pediatric ophthalmology is not as surgically demanding as other ophthalmology specialties. I think that is a myth. I think if you ask any of the panelists and you look at our surgery schedules, you will definitely say that is definitely surgically demanding. The other big myth about pediatric ophthalmology is that you don't make as much money. You do a fellowship and to make less money than you would if you were a general ophthalmologist. Myth. We've got the numbers, and that is a myth. You make a great living, as we're going to talk about, and it's definitely a myth that you don't make as much money. Pediatric ophthalmologists are the leaders in ophthalmology in general. Past AAL presidents, we have tons of people as chairs of ophthalmology departments. The director of the National Eye Institute is a pediatric ophthalmologist. We have a great research consortium. And one of the things I want to stress tonight is there are also fantastic private practice opportunities. The vast majority of pediatric ophthalmologists are, in fact, private practice. In a nutshell, we're pretty awesome. And as we kind of go further on tonight with the panelists, one of the things that we'll look at is some of the American Association of Pediatric Ophthalmology and Strabismus opportunities for medical students to help them along in this process. But I'm going to end there. If there's any questions, please include in the chat or the Q&A. But I'm going to hand it off.
There's a question already about uveitis and autoimmune conditions, if that's incorporated into pediatric ophthalmology.
Yes and no. It depends on where you are. And there are some places where pediatric uveitis in rheumatology is very strong. But uveitis in general is also a very, very, very small specialty. So therein lies the reality that it's hard to have both in the same place per se. But for example, we deal a lot with the pediatric uveitis kids, and because we have a great partnership with the pediatric rheumatologists. David.
I was just going to weigh in. So last week, or 2 weeks ago, I diagnosed a child with toxoplasmosis. So this was a uveitis that's in the back of the eye. It's a little parasite causing inflammation. And I consulted my retina buddy with a picture in consult, and I'm treating them and been managing them for 2 weeks, and they're doing awesome and getting better. So that's the one thing cool about pediatric ophthalmology is we're very subspecialized in a way, but once you hit the kids, we're also very comprehensive. So we kind of get the best of both worlds.
David, why don't you start there? Tell us about your story.
Absolutely. Okay, so my name's David Scanchi. I was born in Philadelphia, but I grew up in Utah. After high school, I served a mission for my church for 2 years down in Brazil. I attended BYU, where I got married, went to UT Houston for medical school. I had 2 daughters in medical school. And then I went to Michigan for all the rest. So my intern year, ophthalmology residency, and then pediatric ophthalmology. In medical school, I was going to do some trauma research. Between my first and second year of medical school, I was at a friend's wedding in Utah, and I was talking to a LASIK surgeon, and I told him I'm going to do trauma research. And he said, "That's a terrible idea." He goes, "You should fly out to Utah and do research with me." So I did LASIK research for mostly cornea and refractive research for 10 weeks, and I just fell in love with ophthalmology. I had a job lined up, and then I went to Michigan and fell in love with pediatric ophthalmology. I loved all the different surgeries in ophthalmology, but the pediatric ophthalmology clinic was an absolute joy. Every day I went there, I just loved it. And I loved academics, I loved teaching, but ultimately I really liked the opportunities of autonomy and efficiency that private practice provided me. And so I actually applied to both academic and private practice jobs. And I'm actually in my first year of practice down here in Fort Worth, Texas. So I also, just to highlight what Hawk said, if anyone wants to talk numbers or money, I can tell you what I was offered both at academic and private practice, and it is way more than I ever expected. When I decided peds, I talked to my wife and I told her, hey, I'm so sorry. I know you thought I was gonna be a cornea surgeon. I am in love with peds. We're gonna be poor. Is that okay with you? And she said, yes, that's okay, as long as you're happy. And I'm not poor and I get to do peds. So it's awesome.
I think we should end there. No, I'm just kidding. And on a high note, no, there's even more highlights to come. Honey, do you want to go next?
Sure. My name is Honey Hersey. I'm a pediatric ophthalmologist over at Baylor, Texas Children's. I actually was born in the Philippines and actually immigrated to the US, lived in New York for a bit, and then we moved on to Texas, and we've been there since. Went to college at UT Austin and then medical school at UTMB Galveston, and then we decided to go our way to Ohio State. And so we moved to Columbus, and that's where actually did my ophthalmology residency. And then for fellowships, we are applying everywhere. And as soon as I matched into Texas Children's, my husband was super happy because we were moving back to his hometown of Houston. So I actually got into peds. I always thought I was going to be a pediatrician. I wanted to have my own clinic, have my own treasure box to like give, treats to kids and everything else, and kind of watch them grow up. And whenever I started doing medical school, I was like, I really love ophthalmology. I love that I can do surgery and I can do procedures, and I still have the cerebral brain of medicine. But I was torn between that, urology, and vascular. And my husband was like, which one were you happy at the most? And I was like, what, ophthalmology. So did that. And then as I was going through residency, I actually was thinking I was going to do retina and cornea. And I was really torn because at Ohio State, we actually did a lot of peds. We had a very peds intensive, residency where I was tended to be a black cloud, and we were on call every 2 hours, like every 2 days or all the week. And my husband, he was in Cleveland doing his medicine rotation or medicine residency. And he was like, you know what? Even though you were on call every other week, that was the happiest you were at. And it made the decision because I get to do retina, I get to do ROP, I get to do cornea, I get to do peds. And so I love it. And it's a great one for also work-life balance. Even though I'm in academics, I do actually have residents. I'm also the fellowship director, so I get to train fellows. And my kids call them my big kids, so they know who, who I'm teaching on there. One of the things is you never get bored in peds because you actually can pick and choose what you want to do. You can definitely be, if you wanted to do more uveitis, if you want to do more ptosis, be a strabismologist, you can. You can wear whatever hat you want to do. And one other advantage, especially, is the collaboration. Like, just like for the uveitis, I've been able to diagnose like, hey, you have intraocular lymphoma, and then we get you treated, and then to see them bounce back is great. And every day is always just fun. I tell the kids I get to just play the whole day because I'm not the one who does the eye drops. I just get to play and be silly the whole time. And so it's always fun.
Thank you, honey. That's just we should end there as well. No, just kidding. There's even more stuff to come. Yasmin, do you want to go next?
Sure. Hi, Hawk. So hi, everybody. Thanks for spending your time joining us. We were really excited to see all of you, over 100 people here. So my story is that I also grew up overseas. My father was an engineer and built embassies for the country of Kuwait. So even though we were initially in Chicago, he took a job there, told my mom it was going to just be 2 years. Well, 12 years later, we were still out there. So it was an international school I went to, came back to Chicago, which is kind of our home base. did a lot of my training in the Chicago area, actually lived in the building that I think Hawk works in right now. It used to be called Carriage House, Dolly Galter Carriage House. Is the slowest elevators probably in the whole city of Chicago. And I lived on the 26th floor, of course, but now it's the Lurie Children's Hospital. It's an amazing place, but I went to Northwestern for medical school, and I ended up doing my residency at the Mayo Clinic in Rochester, Minnesota, and I had a wonderful mentor. So my husband at the time was working for a consulting firm, and unfortunately, he was working in Pennsylvania while I was doing my residency in Minnesota. So it was really hard to travel back and forth for him. So he thought, okay, well, I could do this for 3 years. Yasmin's going to she's going to go into comprehensive ophthalmology, and we'll be done. Well, the very last rotation of my second year was pediatric ophthalmology and strabismus. And I at that point was sure I was going to do adult cataract surgery. And I remember being in the operating room and doing all these amazing adult strabismus cases with Jonathan Holmes. And at the end of the rotation, the very last day in the OR, he said, I really, really think you should do pediatric ophthalmology, at least think about it. And I remember thinking there and thinking, I don't know if I'm going to be happy doing only adult cataract surgeries. Like, I just think that I need something more challenging, and adult strabismus is very challenging. So you get to work with adults and kids. And when I broke it to my husband, I think his shoulders slumped for probably about a minute. And he said, okay, well, if this is what you really want to do, a fellowship, that's fine. I'll travel another year. And honestly, it was the best decision I ever made. So I also have a practice where we do everything: pediatric cataracts, glaucoma. You don't have to give up your intraocular skills just because you do pediatric ophthalmology. Many of us do pediatric cataract surgery, pediatric glaucoma. We put tube shunts in. We're doing the lasers that Honey was talking about, retinal lasers, and really everything else, and also adult strabismus. So it's a wonderful field. Academics, one of the things I think I wanted to bring up that was surprising to me was I never envisioned that pediatric ophthalmology as a career would also involve a lot of global ophthalmology, global work, medical missions, also traveling for conferences. Many of us have been able to participate in academic and other global meetings, anywhere from, giving talks in Australia, Japan, Istanbul, Spain, Argentina. I mean, these are just some of the places where AAPOS and other pediatric ophthalmology societies will have meetings. And if you want to be involved in global ophthalmology, this is a wonderful field, because there is always an area where they're looking for speakers, they're looking for planners to participate and present at these meetings. Hi, Hawk. I think he's frozen.
Oh, no.
I think you're right.
I was waiting for him to say something like, great job.
Well, there's a lot of questions, so maybe we'll just
Okay.
start to
Okay.
toss those out. One was speak to the differences between working with ROP as a pediatric ophthalmologist versus as a retina specialist. So, I mean, any of us can take it, but
Go ahead, Honey.
Yeah, I think it just depends. So like where you are at. And so where we do from screening to AVAS and into the laser. The only time that we do need our retina colleagues is if they need a vitrectomy or something else. And so we do have a hand-in-hand relationship with them. But, I do my own FAs, so I kind of just, that's what my interest was. And so then I kind of learned it, and then it went and did it. Now, many ROP places have it as retina specialists only because there's not enough pediatric ophthalmologists. So we need more.
there is also another question about the wonderful experience of working with Dr. Soni, but wondering too, what is the other side of it? What are our hardships? Just to get an understanding about what to really expect.
I also see that there's a secondary question about the same thing, about, maybe dealing with very difficult cases. Yeah, I think pediatric ophthalmology is, really special in the way that, you can deal with really parents when they have their newborns, and they're worried about everything about this baby. And then, you are there telling them, giving them a diagnosis, and maybe it's a diagnosis where, you know that they're not going to have a very good vision, the rest of their lives, but you could actually do your best to manage, that and help them with it. So, we're really equipped to deal with complex pediatric patients, even patients who really, the vision prognosis is poor. But, I've been really amazed at how resilient children are, even children who have to learn Braille, that children will still grow up and do well in school with the resources we have now. We are at the University of Wisconsin. We are part of the Lighthouse Guild. So we're one of the centers in the country that have a low vision basically directorship. So we have 2 directors in low vision, and they do a lot of teaching of our residents, but also have a presence in adults and pediatrics. And there's a lot more technology out there I was just talking to a parent today about, her child who has cortical visual impairment, to use a fixation tracker as a communication board where she can communicate now, with her parents saying yes or no. So, and that's just with her eyes. So there's a lot of technology, I think, that's going to be happening in your generation. But, I think that, we get more and more equipped to deal with the parents. And honestly, I think we're much better equipped to deal with them than some of our colleagues who don't see children.
One thing I want to add to that is whenever I think of my patients, it's not just the kids. It's actually, you also get to be advocates, not just for the kids, but also for their families and their parents. And, we at Texas Children's, it's super busy. And so we actually will get inpatient consults. And so sometimes I am the one that has to say, hey, we need to get a scan and there's a brain tumor, and I'm breaking down these news. But then, like Dr. Bradfield had said, kids are resilient, and it's just amazing to see them afterwards. And then they come in to see me in the office and they give me a big hug. And even if it's not a wonderful, you know, uh, outcome, you can still be supportive, and the parents and the families appreciate that. And sometimes, yes, I might be a little bit slow because I took the time to talk to them and really break down the things. But, having those families really trust you and, feel for you, it actually helps. And I actually treat them just like how I would want to be treated. And I tell them, hey, I'm a mom also. I know how it is. I get it. It's hard to patch. It's going to be hard to do the massages. And so you're able to connect. Now, how do you deal with that emotional burnout? I think that is one thing that is sometimes hard, because you're going to have all day where like they're crying and all you hear is crying kids sometimes. But then you have the good days also where it's mixed in with crying kids, but then you're also singing Twinkle, Twinkle, Little Star on a 10-year-old autistic kid to actually connect and like hold their hand and actually get them to see. So I think you got to take the good with the bad, just like how you would in any practice. And I always just now, as soon as I get home, I just kind of like decompress, count my blessings. Thank you that I got to take care of these amazing kids. And some of these kids are now, I tell them my ROP babies are now, some of them are taller than me. Some of them are going to college. And I'm like, it's amazing seeing them. So you got to take the good with the bad, but it is still something that we love.
I think that there's so much more gratifying that comes out of every day. You feed into more than you take away from the pot. And I think for everything in medicine, there's always loss. We all struggle with parts of it where there's someone who we're close to and we lose them. And in fact, I had thought about oncology for a minute, and I thought I couldn't do that on a moment-to-moment basis. And while it's still losing anybody or having any real morbidity in any person that we care for is really hard to deal with, we still get so much more happiness. The ROP baby that is doing great in college, now the ability to see someone who was really poorly sighted at a moment that you were able to help, and now people don't even know that they have a visual limitation. It's amazingly gratifying. So there is another question, kind of going back to pediatric ophthalmology and international peds, talking about the opportunities that exist. Are there groups and companies if people are interested in international pediatric clinics and strabismus surgery, you know, how does that sort, since most are cataract? Hawk, just to bring you up to speed, most of us have introduced ourselves except for AJ and I, but we're kind of handling the chat at the same time.
I apologize. Oh my gosh, here we go again. I thought, oh my gosh, I'm so scared now. I don't want to touch anything. I apologize. I think for international ophthalmology, I think the thing about peds optos, have Prism can travel. I'm kidding a little bit. Peds optos, strabismus, pediatric cataracts, you can do a lot on international trips. It's not something that you need a ton of equipment. I was did a mission trip in Guatemala, and we were using the ultrasound from the OB ward to determine whether we should do a cataract or not. So you don't need a lot, but there's a lot of opportunity there. AAPOS has a big push for international ophthalmology, especially prevent blindness, and they're doing a lot in Africa with RRP, for example. There's a lot out there. There's a ton of out there for peds opto in international work. If we may pause, and Ajay, do you want to introduce yourself?
Sure. Can you hear me, Hawk? You can hear me? Okay, awesome. Thank you. And thanks, Hawk, for setting this up. You are the most amazing ambassador for our specialty. So appreciate this opportunity. My journey to pediatric ophthalmology, I grew up in the Philadelphia suburbs and went to medical school in Pittsburgh and decided to go into ophthalmology. I was a resident at the University of Maryland. Never thought about pediatric ophthalmology when I started. I thought I was going to do one of the specialties, probably retina. But I think that, we had combined rotations at the time. So I was doing retina and peds at the same time. That's just how ours were constructed, meaning some days you're on this, some days you're on that. And I think I just saw such a contrast. And pediatric ophthalmology was so refreshing in terms of opportunities to make timely interventions that just had a lifelong impact. I also really liked the ability to step back and kind of see the whole patient, whole family, and think about what is best for that child. And it was just a really unique pocket in ophthalmology. And one really important aspect that I always wanted out of a career in medicine is I wanted to feel like I was filling a need, that I was doing something that was of value, and really there weren't enough of such a thing out there. And pediatric ophthalmology is exactly that. I think there are very few communities where there are enough pediatric ophthalmologists. So wherever you go, you will feel valued, you will feel needed, and you'll be making a difference on a daily basis. So that was really important to me. So after residency, I went to Indiana University for my pediatric ophthalmology fellowship. Shout out to all the IU folks out there. There's a few of us on the panel and in the audience. From there, I briefly did private practice, but I felt that for me, I wanted to be part of a team. And I wanted just there to be more facets to my career than clinical care. So I wanted to be doing some teaching, and I wanted to be doing a bit of research and just stay up to date and involved with my organization. So academics kind of was where I headed then. So I joined Penn State. I've been here about 10 years. Couple of years ago, I made a transition. We had an opportunity to move away from our main eye center and move into a pediatric home. So that's where I practice now. We're in a pediatric subspecialty site. So I have office space alongside all my pediatric colleagues, which is really different than being alongside all of my ophthalmology colleagues. I certainly miss them, but it's allowed for a lot of collaborative care with my peds colleagues, neurosurgeons, oncology. As Hawk said, that's another facet of our field that I really like, is collaborating with rheumatologists, oncologists, neurosurgeons, and just, again, looking at the whole patient. So that's my practice nowadays, is doing mostly clinical care. I teach, we have a residency program, and I supervise a lot of students, many of whom are here. that's what I do. And it's exciting. And I agree with all of what Hawk and the other panelists said. It's pediatric ophthalmology is everything at once. It's challenging, it's busy, it's hectic, it's rewarding, it's fun. So thank you all for being here, and thanks for a chance to share my story.
Thank you, Ajay. Danielle, do you want to go? There's tons of questions. Oh my gosh, you
There
guys
are so many questions.
fantastic. The questions really, I think, speak to the audience's interest and really their knowledge already. You guys are super on it. Yeah, Danielle.
So I am a pediatric ophthalmologist in private practice up in Massachusetts, Beverly, Massachusetts, actually on the hospital campus that I was born in. So I started out there exactly across the street from where I practice right now. But after finishing high school, I went away for college to Cornell. I went away for medical school to Emory. I went to Medical University of South Carolina for my pediatric ophthalmology fellowship, which is where I met Hawk. And after I came up and I worked at Boston Children's Hospital for 8 years full-time and another 7 years part-time. Mainly my choice to go into pediatric ophthalmology has already been said, but I would say in a nutshell, it was hands down the most fun that I had during my residency. I didn't want to do it because it got kind of a bad rap that you can't make money and it's miserable, like, you know, dealing with parents all the time. So I was gonna go into cornea. I applied for my fellowships and then I thought, what was I thinking? And I changed and I did peds, and my roommate was like, that was the only time you were really happy. Of course, that's what you should do. So I went into pediatric ophthalmology, went to MUSC because in part Ed Wilson is very focused on international work. And so 2 times that year I traveled to Guatemala with a program that he has done, and I continued to do that. Even this past summer I was there again. So I've done it probably about a dozen times. I've traveled to Nepal to do international work. I've traveled to El Salvador to do international work. The opportunities abound. Strabismus surgery is incredibly wonderful thing to be able to do in a community that there might not be a lot of follow-up. And so while the program in Guatemala we have has got a really strong connection, there is an ability to kind of go into a country and make a big difference in the lives of people by straightening their eyes, allowing them social opportunities within their own countries they might not otherwise have, and minimize your risk by leaving and not always having close follow-up, especially for people that live pretty distant to where you might have met them and operated them. So that was definitely a big factor for me. I liked everything in residency. I wasn't interested only in one thing. I wanted to do everything. And I felt like if I went into cornea, I'd be dealing in like a 500 micron area, mostly with dry eyes. That didn't sound as much fun as like pediatric cataract 1 minute, nasolacrimal duct obstruction the next, screening for retinopathy of prematurity, just giving a set of glasses to a little kid who can't see. All of it is just fun. And I also enjoy the part of explaining to the parents what's going on and listening to them and understanding things that they're concerned about or holding their kids back, or the ways in which, you know, they're developing and they really feel grateful. And I just as has already been said, every day is a pleasure. And every day is full of some screaming kids. Some days, many screaming kids, but you know, right. You just take it all, wrap it up. You know, it's not your fault half the time, at least once in a while. And yeah, it's just a pleasure. And so it's nice to be here. I made a transition from academics into private practice personally because I needed better work-life balance. So I was commuting back to my community where I grew up, where my family was, and they were raising my kids. My husband's family is in the same area. And eventually I just got so tired of commuting and trying to make the balance with all of the other obligations that I had with academia that I started my own practice on my hospital campus. I know the different pediatricians that are around. I've worked really well with Boston Children's, where I had been for all those years. I still, when, have a kid with Lyme meningitis, they go right in. If I have a kid who I think has a brain tumor, they go right in. It's easy to to still facilitate, but I have really good access for people that sometimes it gets really hard to access some of the bigger academic centers. And I feel really comfortable that I've seen so many sick kids that it's an opportunity to get them where they need to be as quickly as possible. So I have been really, really happy being in private practice. I enjoyed academics a lot as well. But for me, the work-life balance has been amazing doing what I'm doing. Good, Hawk.
That's amazing. There was a question in there, and I'm not sure we can answer it directly, but it has to do with private practice and private equity and so forth. And certainly this is not a scientific answer per se, but in discussions around the country in AAPOS and so forth, and I wrote it in the answer. I wonder if there's the pendulum or the private equity trend, it may be reaching its max and swinging back the other way. Again, not scientific, but anecdotally, we know a lot of people like Danielle and David who are like, they're going into private practice, strong private practices who are not, looking to be bought out or anything, and new people coming out and starting their own practices. So it's an interesting trend I hope will continue, but again, not scientific, but I don't know if Danielle and David could maybe answer that sort of pressure from private equity question.
Yeah, that's my general sense too, Hawk. I don't have, great numbers to back that up, but I think we're kind of hitting a peak when it comes to private equity. We'll see how
Yeah.
it plays out. There was also a question in the chat about salaries. That's a very challenging, nuanced thing to answer because there's a lot that goes into that. But just to ballpark some numbers for what I was offered, so you can kind of have a sense for academics, between me and a couple, people who graduated my same year, just to give you a sense of what was on the table. Academic offers, we saw everything from 250 to 350 starting salary. I will tell you 350 is high. So if you're, if we're talking specific areas in the country, you might not see that number as a starting salary at some academic institutions. And then that also number might look different if you're doing a lot more research or teaching or have more protected time, that number would likely come down. Private practice, I saw 270 to 350, but with bonus potential and things like that. Again, these are starting numbers, and I had better offers than my cornea co-residents or friends and things who just graduated. And then again, it's just so much to balance. It's hard to just talk just numbers. You have to take all the other things into consideration. Also, ROP offers extra money. If you're willing to take call, that's extra money. And I'd be happy to talk on the phone if you guys are trying to figure out finances and how to value other aspects like research, teaching, and all of that stuff. Because I think those are really important too. And you'll quickly realize money's not everything.
Correct. That's David, thank you for mentioning that last point. It really obviously you backed up the numbers per se, but again, yeah, it's everything else that comes along with it that makes it worthwhile. Yeah,
it matters. You need financial freedom. You need to be able to pay for your kids' college, and I promise you'll get that, and you'll be so happy doing it. And I think that's ultimately what you're gonna value the most long road, is finding something you're happy doing for a career.
I think that in the past it had been much more heavily weighed towards private practice than academics. And somewhere around 2020, it switched, and there's now less than 50% in private practice and more than 50% in academics. So that's a somewhat recent change. I don't know that that's a persistent forever change. There's probably a lot of forces that are bringing people into health systems, a lot of economic forces. And I think those are real, especially depending upon different places that you live. I live in Massachusetts, but that doesn't mean that I can reflect what's happening in California. Everything is different around the country. I can say that there are opportunities that I have found in order to work within health systems, but still be an independent person within the health system. And I think that's been really nice for freedom and for the ability to make some personal decisions, business decisions, as well as just what's right for me without feeling pressure to perform in a different way. And, I kind of didn't know if I should have been doing it when I went out on my own because everybody else was folding into bigger systems. It felt like the wrong choice, but I have not found that to be true. And that was about 9 years ago. as far as private equity, I'm with David on answering. I don't know that I can say what direction it's going to go with private equity. That has certainly happened, but I think there's time before we really know the end result.
Thank you, guys. Thank you. There was another question about maybe needing to do an additional, maybe you guys already answered this, maybe needing to do an additional fellowship per se. You know, we have a couple of people in my practice who are have done both plastics and pediatric ophthalmology, which makes them really, really awesome for us. I think it all depends. I think it all depends on really what you're interested in. If you're interested in doing plastics and peds, it's actually not a huge stretch to do 2 fellowships. But in general, I think you get such good training in our fellowship programs. You know, honestly, when I was at Michigan, you know, when I graduated, I was like, could I please stay another year? I'm not sure. I'm not sure I learned everything. But the truth is, you learn. You may not see everything out there, but you've seen something like it. And like, I don't know exactly what this is, but I've seen something. I know exactly how to start this, how to work this up, and really get to the bottom of this, even though I've never quote unquote seen this before. Again, doing an additional fellowship is certainly an option, but I think making good friends and learning from your colleagues is just as great as doing an additional fellowship. When you call up your rheumatologist and ask for advice about drugs like that, or your oncologist, you learn just as much and you lean on them, and it's certainly a two-way street, and it makes it that's what's also interesting about it.
Yeah, I would like to just kind of add to Hawk's statement. Like many of the fellowships, you actually get a lot of that training. So where you would feel comfortable to do glaucoma, or even do like some oculoplastics with ptosis and doing ptosis repair, etc. I think one thing that sometimes that people may want to do another fellowship is if they're ever interested in doing a neuro-ophthalmology fellowship on top of a pediatric ophthalmology fellowship, just so that if there's more neuro-ophthalmology that they might be interested in, and add that to their strabismus, I guess, deck of cards of what you want to do. I feel like that's what I've seen sometimes, but I feel like, you know, in peds, it's very collegial. You can always ask a friend, you can always phone a friend, and you can actually work with a lot of subspecialties, you know, your cornea and uveitis. So you're never actually by yourself. And I feel like we're all very nice people. And so then it's like, okay, and we all help each other out.
Yeah, I would agree with that. I think that most fellowship programs now really train broadly. They've really really gone far from the mostly heavy strabismus training that I think that we saw a lot of that in the 80s, maybe 90s. But so I think a lot of the other things that you've listed are covered in some of these broader fellowships. I would say that, you know, the few things, maybe pediatric retina, peds, maybe cornea, if you're very interested in doing a lot of corneal transplants, dealing with things like Peters anomaly, some of these corneal dystrophies, you know, that probably would have a role. But many of us do peds plastics already ourselves. Like we don't, you know, because we manage the amblyopia as well. And parents love going to one person who can do everything, who can do the surgery and then also manage the amblyopia.
There's another question, interesting question about declaring for peds ophtho too early. Actually, we have kind of a segue. I have a student rotating here in Chicago at Lurie Children's from Portland, one of AAPOS's scholarship away rotations, which you guys should investigate. And she was wondering about that. Oh no, this was actually somebody from a medical program in Ohio. I apologize, somebody else. I'm like, well, when you apply for residency, obviously the right answer is I don't know yet. Something else could catch my eye, but I don't see any program director saying, "Oh, you're really interested in peds ophtho." They're going to hold that against you. You know, when I generally give advice for people on their applications, I want to see somebody who's passionate about something. I joke around, it could be basket weaving. But if you took that to the nth degree, that's what I want to see. So if you took your interest in peds ophtho and you really went for it, yes, your interest could change during residency, but you've proven that you've really gone for something. And I don't think that's something you should hide at all.
I just wanted to add to that, Hawk, that there are, and many of you may know this, that there are a lot of fellowship programs that are not filling in for pediatric ophthalmology, and there's a big workforce issue. So we really need people who are really committed and interested to practicing pediatric ophthalmology all over the country. It's actually a global issue, but there are a lot of residency programs that are looking to keep their own residents to go into their pediatric fellowship position. And so if they find a resident in their program, I know we do this too in Wisconsin, where we think, gosh, somebody's a really good fit for peds. We're going to actually make sure that they get a lot of pediatric ophthalmology experience and a really good experience on our peds rotation so that they would consider staying for our fellowship. So I actually don't think it's a bad thing to tell people that you're interested. In fact, I think there may be residency programs who have a fellowship program that would be very interested in having somebody like you as a resident.
I don't know that I can give you global advice, but I sat on the residency committee twice, interview committee for University of Michigan, and we gave preference to people who wanted to do peds. But I would definitely agree with what Hawk said regardless. I think as long as you're passionate about it and you show that you've motivated and accomplished things, I don't think it would hurt you.
There was a question that kind of got lost because there's been so many good questions about things like midwives, and therefore in that same manner, kind of pediatric optometrists and the impact that it has, other people that kind of work closely within our field. And that I kind of linked it, even though they're very different, to the work-life balance, and if you can maintain it, if there really is such a high demand and so few people practicing. So I link them because I think it's a way to have a nice collaborative relationship as opposed to an oppositional relationship. Is there some opposition between optometrists and ophthalmologists? Absolutely. There's a lot of things that go on within two independent fields where the lines kind of blur. But I think, and I could be biased, but I find in this area, we have a training program for pediatric optometry residents in Boston. And I find them incredibly well trained and very interested in coming out and working with ophthalmologists, pediatric ophthalmologists, seeing disease, but not being the ones that have to take care of all of it, knowing that their background is very different than ours. And their background is different than ours in a way that's really positive. I have a person who started with me just a few weeks ago, fresh out of her residency. She is fantastic. She is just adding to how much the kind of care that we can give. That kind of collaboration, I think, exists. There is definitely going to be some people that aren't happy to collaborate in that way, but I haven't found it to be something that's a barrier personally.
Well,
Three pediatric. Oh, go ahead, Hawk.
No.
I was just going to say we have 3 pediatric optometrists in our group. So I'm often working side by side, and they are awesome. They often don't want to deal with the pathology and complicated patients. And I don't want the patient who failed a vision screening because they're +1 hyperopes, or something like that. And so we're able to work together and I think increase access to care. And then I'm able to operate kind of at my highest level when we're both doing our job. So with pediatric optometry, at least, I haven't seen really much issue at all. And it's been a very positive relationship. And we want to hire another one. We love them.
We have the same actually at our program where we have like 4 pediatric optometrists, and it's great because, they want to see the failed vision screen. One of them does our autistic patient, so that is her specialty. She wants to do the special needs kids. Another one wants to do low vision. Another one does a lot of, contact lens. And so then anytime that they have strabismus, they're like, shuttle it to us, anything complex. And so then our surgical numbers are always just helped by that.
The linked question that Danielle was asking about, work-life balance and the shortage of pediatric ophthalmologists. I think I think all of us here work hard. And we all work hard. We're busy, but to a certain extent, because we are in pediatrics, we how to say this? We have an eye, wink, 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 toward that work-life balance, appreciation, and so it's the flexibility is there. Danielle's a great example. You will make the time for things that are important for you, and the flexibility is there. Yeah.
From a job offer perspective, again, just to echo with Hawk, I work hard. I'm on call every fourth weekend. I'm a weeknight, like every Wednesday, or I'm actually on call right now. So every Thursday night I'm on call. I do ROP at night sometimes, but if I wanted to, there was job offers where I could have worked 3 days a week, 7 to 3. And we need people in pediatric ophthalmology. And so if that is what you want, and that's how your balance wants to be, you'll take a pay cut for it, and we will love to have you part of the field, because we need everyone we can get. These kids do, and that's true for a lot of pediatric subspecialties right now. So there's flexibility for sure.
Definitely, I think you have, even in academics, you can make it also work in that way. I remember whenever I first started, I was like, oh man, I have to be able to like pick up my kids. Now my kids are starting school. What do I do? And I talked to my chief, and he was like, you know what? Then stop your last patient at 2 and get out by 3, pick them up. Oh, okay. And I'm still like, you're still seeing patients, you're still efficient, but I get to do a kid drop off. I get to do kid pickup. If there's something that is important to my kids that I have to be there, I can say, okay, well, as long as I give them enough lead time, hey, I need to go step out for a little bit just so I could go to my kids program, and I'll be back. Just because it's close. And then I just kind of drop over. And so I think you can make it work. Now, is it still tough? Are there still things that I will miss? Yeah, definitely. If I'm on call, the kids know if I'm on call, they're like, Mommy, can we go to your clinic? And at least it's fun, because if they come to my clinic, there's movies on the TV and they get snacks. And so, it's actually kind of funny, because I remember pre-COVID, I had 3 kids under 5 at one point, and I was rounding with my double stroller down the hospital hallway, and one of the nurses actually was like, hey, can I was like, yeah, I can watch your kids while you go see the patient with the resident. And then we came back out. Okay, bye guys. And the kids were like, thanks for the snacks. So I think you can make it work either way.
Oh, go ahead. Sorry, Danielle, go ahead.
No, it's funny because I have chosen to take all of the weeks that my kids are off. I don't take the whole summer off, but I take all of the holidays, all of the vacations. And so my parents, when they're checking out, are like, oh, it would be great if I could come back during February vacation. My staff's like, no, she's not here then. Like, it's just not, it's how I chose to set it up, and it works. People just take their kids out of school on a different day, and it's okay.
We've only got a few minutes left, and I just want to thank all the panelists. You guys represent so well. Thank you guys so much. As we end this, there are a lot of questions about how do I approach, going through the whole process of residency or peds opto. And I think the number one thing tonight is, one, this is recorded. You'll get the recording in a couple of days. 2, we'll send a survey with, hopefully we'll try and get everybody's contact information on there. So if you're thinking about this, the best way to move forward as you start thinking about this is just contact one of us close to you, or have the connection. If if you grew up in Idaho like I did, you're like, I'm going to make that connection. Just contact one of us. And here's the thing about peds opto. I think we may not have the answer, but we're not going to say I can't help you. Okay. That is the ethos of peds opto. I think the fact that we're all from different places and we love what we do, and we talk about collaboration, we really mean that. So just connect with us is really the next step.
Oh, can I also just put a plug?
Yes.
AAPOS on their website actually has information for a dedicated pediatric ophthalmology rotation for medical students. And the next batch of students that we're going to be looking at applications is likely next spring, summer. So if you're interested and you do not have a program at your own institution, you should look at the website and then apply, because then you will have instant mentorship. These are people who really, really want to take a medical student and take you under their wings for up to a month at their home rotation, and you'll get a great experience. And I saw that there's a question about how to be competitive, and I would definitely say doing a away rotation can really show your interest, and you can get a recommendation letter that way.
Any other parting remarks from the panel? If not, I have a dazed and confused quote that I pulled in for another webinar that I'll recycle. So one of the questions I did some of you are here from the AAP webinar. You know, they were asking about the grind. I'm like, well, I'm going to pull a dazed and confused quote, and I keep getting older, but the kids stay the same age. The kids are wonderful. They're hilarious, and they make it worth it. Thank you, everybody. We hope to see every one of you soon in some shape or form. But contact us, and good luck, and hopefully hopefully just spread the word. Thanks, everybody.
Thanks, everyone. Have a good night.
Good night, everybody.
Good night.